Hi, I'm Precious. For my psychological assessment class, CLP 6436, I will be presenting my client case presentation on his case conceptualization. So my client's name is Harold. He's a 72-year-old divorced man who always enjoyed social events. He could have a few drinks, smoke a few cigarettes, enjoy his friends, and wake up feeling fine the next day. Even as he got older, he could hold his own at a party. One night when he was driving home from a gathering, he swerved to miss a car that he thought was too close to the line, and he ran off the road. His car suffered some damage. He hurt his back and neck. The doctor gave him Flexerol, which made things much easier. He was already taking a mild tranquilizer called Klonopin for his nerves, but that prescription was from a different doctor. He was sure that there would be nothing wrong with adding one pill a day. When he started to have more trouble sleeping because of the pain, he decided to take one extra pill and sometimes added a beer. That made it even easier to relax, he claims. Before long, Harold could not get to sleep without the tranquilizer, a double dose of pain medication, and a beer. His reason for referral was for a psychological evaluation by his medical doctor for the purpose of assisting with treatment planning. My clinical impression for Axis 1, I would diagnose Harold with 304.8 polysubstance dependence with physiological dependence. And this is because the client follows a maladaptive pattern of substance abuse, leading to clinically significant impairment as manifested by a need for markedly increased amounts of a mild tranquilizer, increased amounts of beer, and a double dose of prescribed pain medication to achieve desired effect. The client also experiences markedly diminished effect with continued use of the same amount of substance, which is why doses were doubled in order to elicit lethargy, in order to help him sleep. A great deal of time was spent in activities necessary to obtain the substance, such as driving to multiple doctors to accede to different prescriptions for different medications. The client reports unsuccessful efforts to cut down or control substance use. Upon assessing the biopsychosocial report, the client's symptoms and behaviors do not seem better accounted for by the Axis 1 disorder, schizophrenia, and subsequent subtypes. The client has not reported any signs of hallucinations, paranoia, or delusions. Axis 2 code V71.09 is no diagnosis. That is the absence of any personality disorder to me. Axis 3, I would say his neck and back pain from previous car accident. Axis 4 is previously able to sustain an active social life with friends who are now growing distance because of his substance use. Axis 5, GAF 65, which is some mild symptoms, difficulty sleeping, and some difficulty in social and occupational functioning, but generally functioning pretty well as some meaningful interpersonal relationships with siblings. My recommendations, treatment for this client, Harold, is to continue individual sessions with therapists, including speaking about his divorce out loud, substance abuse therapy with a professional, hypnotherapy for changing his poor sleeping habits, admitted to rehabilitation center for treatment, and my educational suggestions is to continue to seek higher education, speak with an advisor to help organize goals for completion of coursework. And thank you guys for your feedback. I would especially consider cognitive behavioral therapy for his irrational thinking because he cannot sleep without medicine. And I got a suggestion about decreasing his GAF to 60 because of his flat affect and social deficiencies. To answer your question, I do not think that this client would suffer from 291.89 alcohol-induced mood disorder with manic features because he has no history of a manic episode, and alcohol dependence better suits his case than alcohol abuse because, according to the DSM, dependence preempts abuse. And that is my client case presentation.